Um, okay, so hi everyone. I'm Mariam Mahmoud. I'm a fifth year medical student. And today I'm going to be explaining to you the heart valve disorders and murmurs. Okay. So for the objectives, first I'm going to be explaining the normal heart sounds. And then I'm going to explain the abnormal heart sounds and then the valve abnormalities and how it affects the PV loops. Okay. And then there's going to be a few questions at the end. So first, to understand the heart valve disorders, you need to understand what are heart valves, right? So does anyone know what's the function of the heart valve? If you can open your mic or write on the chat. No. So basically, heart valves, they prevent the backflow of blood. So basically, if the heart is moving from the atrium to the ventricle, it won't allow it to go back to the atrium. So this valve, can you see my pointer? Okay. So basically, this heart valve is called the aortic valve, and then this one is called the pulmonic valve, and then this one is called the mitral, and then this one is the tricuspid. Okay. So basically, the aortic and the pulmonic valves are semilunar, and the mitral and the tricuspid are called the AV valves because it's between the atrium and the ventricles. Okay, so what's good about these valves is that you can, there are places on the chest where you can best hear them. Okay, so basically, you can see that here, the aortic area, it's on the right side of the sternum in the second intercostal space. You can hear the aortic valve, it's best heard here. And then the pulmonic area is on the left side of the sternum in the second intercostal space. And then the tricuspid valve is on the left side of the sternum in the fourth intercostal space. And the mitral area, it's on the left side of the sternum, fifth intercostal space in the mid-clavicular line. So basically, if you see the clavicle in the midline of it, you will find the mitral area. Okay, so there's a mnemonic called ape to man. So to memorize the places of the heart valves. So aortic, pulmonary, tricuspid, mitral. Okay. Okay, so now for the Wegger's diagram. So I think there's another lecture about this in the the cardiac cycle. So I'll just explain it very briefly. So basically here you can see the yellow one is the atrial pressure, the green is the ventricular pressure, the red is the aortic pressure. Okay. So first there's this bump. So this bump in the atrial pressure is basically because of atrial contraction, okay? So when the atrium contracts, it pushes the blood to the ventricle. And then when the blood is in the ventricle, the ventricle will then start to contract. So when the pressure of the ventricle is higher than the pressure of the atrium, it closes the AV valves, okay? So for example, if we're talking about the left side of the heart, it will close the mitral valve. And then there's the isovolumetric contraction of the ventricle. It will contract until it passes the pressure of the aortic pressure, okay? So then it will open the semilunar valves. So when the semilunar valves open, it will push the blood to the aorta, okay? So then the ventricle will then start to relax. When the pressure of the ventricle is less than the pressure of the aorta, so the semilunar valves will close. So if you think about it, if you imagine the heart, when it relaxes, then the blood will come back, it will push on the semilunar valves and it will close it. Okay? So then the pressure goes back and then the AV valves open again. It will let the blood enter again into the ventricles and so on. Okay, so here if you see that the AV, so here if you can see that the AV, when the AV valve closes, it produces the first hard sound, which is the L. And then when the semilunar valves close, it produces the second hard sound, which is the dub, okay? Okay, so now for the cardiac cycle, so you can see that the ventricular systole, it's the first phase. So when the ventricle contracts, it pushes the AV valves to close, which will cause the first hard sound, S1. And then there's ventricular systole, the semilunar valves will open, the blood is ejected. And then when there's diastole, it will the semilunar valves are closed, which produces the second heart sound. And then in the ventricular diastole, the first part of it, there is the rapid ventricular filling, right? Here you will hear the S3 sound. And when the atrium contracts, you will hear the S4 sound. I'll explain the S3 and the S4 later on, but basically know that S1 and S2 are the normal heart sounds that you hear all the time. And then S3 and S4, they're the abnormal heart sounds. So just keep in mind that S3 is related to volume overload, and S4 is related to pressure overload. I'm going to explain it in more details later on. Okay, so now for the normal heart sounds, we said that the normal heart sounds, there is S1, so it's heard loudest over the mitral and the tricuspid, right? Because this is when the mitral and the tricuspid, they close. Okay, an important thing to know is that the sound that you hear is not from the actual closure of the valves, but it's because of the stretching of the connective tissues, the blood vessels, the stretching of the chordae tendineae, and the rumbling of the blood. Okay, so this is what causes the sound. So basically, for the S1, you can hear a split. So what's a split is that you can hear it as two. So there is a physiological, which is a normal splitting of S1, and then there is a pathological splitting, which is abnormal. So in normal, basically the ventricles, they do not contract in the exact same time. There is sometimes a milliseconds between them. So that's what causes the asynchronous closure of the AV valves, right? So so usually the left ventricle, it contracts before the right ventricle. So the mitral valve, so it will push on the mitral valve, it will close it before the tricuspid. And then there's a pathological splitting, which is abnormal. So this might happen because of the electrical conduction problems. So basically, there's the conduction system of the heart, which is here. So you can see that there's the AV, there's the SA node, and then it goes to the AV node, then the bundle of His, then the right and the left bundle branches. So basically, for example, if there's a problem here in the right bundle branch, okay? So the electricity, it will reach the left ventricle faster than the right ventricle, right? So the left ventricle, it will contract faster than the right ventricle. So you will hear that there is a split between them. This is a pathological split if it's caused by an electrical conduction problem. Okay. Now for the S2, same thing. S2, it's because of the aortic and the pulmonic closure of the valves. So it's best heard over the aortic and the pulmonic areas. So there's a physiological splitting, which is normal, and there's also a pathological splitting. So the physiological splitting, basically you will hear the aortic before the pulmonic. So what happens is that it's accentuated or it's heard more during deep breaths. So what happens in deep breaths? Here you can see the lungs, the diaphragm. In inspiration, it will go down, it will increase the space of the lungs. So basically, when the space increases, what happens to the intrathoracic pressure? So it will decrease, okay? So there's going to be a negative pressure in the thorax, which will suck in the air particles. So it doesn't only suck in the air particles, it also sucks in the blood. Okay, so more blood it will come from the vena cavas. Okay, so the blood flow to the heart through the vena cava, it will increase, and therefore the pulmonic valve, it will take, so there's more volume in the ventricle, okay? So it will take a longer time for it to empty to the pulmonary artery. So it will take a longer time to close. So you will find a split. So the aortic valve, it will close faster than the pulmonic valve, okay? So this is for the physiological, which is normal. And then for the pathological, basically, so if like we said, there is a conduction problem. So if there is a problem in the right bundle branch block, okay? So the electricity, it will reach the left ventricle faster, as we said. So basically the heart will take the right heart, it will take a longer time than the left heart to empty. Is that clear? Okay. So another problem is the conduction defect. It will cause a pathological a congenital defect, which is atrial septal defect. Okay, it will cause a pathological splitting. So if you have a hole between the atriums, okay, so basically there's this part between the atriums, it's open because the left ventricle, it has a higher pressure than the right ventricle. So when the ventricles contract, the blood will pass from the left to the right because it has a higher pressure. So now you have a higher volume in the right ventricle. So it will take a longer time to empty it to the pulmonary arteries. So it will cause the pulmonic valve to close later on than the aortic. Okay. And then another cause is the pulmonic stenosis. It's the same mechanism. Because it's harder to push, it's harder for the right ventricle to push against the valve, so it will take a longer time to empty. So you will find a split between the aortic and the pulmonary, okay? And an important thing to know that the pathological splitting, it's not affected by deep inspiration. Okay, so this is a checkpoint. If anyone has any questions. Okay. For the abnormal heart sounds. So basically, abnormal heart sounds is S3. As I told you, it's volume overload, okay? So S3 is a lower pitch sound. So what happens is that there's a larger volume entering into the ventricle, which causes this S3 sound, okay? So it's best heard over the mitral valve area, which is the left side, fifth intercostal space, mid-clavicular line. So this happens during the rapid ventricular filling. So when the systole ends and then there's diastole, so there is rapid ventricular filling and then the atrium will contract. So during this rapid ventricular filling, you will hear the S3 sound. So S3 can be caused by a physiological or pathological causes. So physiological is if they are a child or thin adults, trained athletes, or pregnant women. Okay, and pathological is because is if there is aortic valve regurgitation or mitral valve regurgitation. So I'll explain it more here. So basically, aortic regurgitation. Here, it's because there's a defect in the aortic valve. So it's so basically, when there's diastole, the blood will pass back into the ventricle. Okay, So why is it volume overload? Because you're not just getting blood from the atrium, you're also getting blood from the aorta. So there is a volume overload. It will cause the S3 sound. And then for the mitral regurgitation, so what happens is that when the ventricle is contracting, it will not only pass blood to the aorta, it will also pass blood back to the atrium because the valves are incompetent. They allow blood to go back. Okay, so when this happens, there is more blood in the atrium. So when there's diastole, there is more blood going back to the ventricle. Okay, so that's why it causes the S3 sound. Now for the S4, it's pressure overload. So what happens is that the ventricle is not compliant. So this is when you hear the S4 sound. So when exactly in the cardiac cycle do you hear the S4 sound? It's when the atrium contracts, okay? So it's during the atrial contraction, and it's best heard over the mitral area also. So there is no physiological causes for this S4 sounds, unlike S3. There's only pathological. So basically, you will get the ventricle to not be compliant when it hypertrophies. So basically, when it's pushing against a high pressure for a very long time, the muscle of the ventricle, it will become more bulky. Okay, so when it becomes more bulky, so you can see here, the muscle here, it's more bulky, it's thicker, so it doesn't comply, it doesn't stretch easily when the blood comes back. So you will have, if for example, what are the causes that will cause the ventricle to hypertrophy? So if it's pushing against chronic hypertension, or if it's pushing against aortic stenosis. So here you can see the aorta, the aortic valve, it's stenosed and it's hard to open. So the ventricle, it will put more pressure to open this valve to allow the blood to come out. Okay, so now for the murmurs. So murmur is basically heard when there is turbulence in blood flow. So basically, if for example, if we didn't take the heart as an example, we took the blood vessels. If there is atherosclerosis, or if there is a narrowing of this blood vessel, you will find that the blood, it will make a sound. It will make a murmur because it's turbulent at that point. Okay, so the same thing applies to the heart. For the murmurs, there is systolic and there is diastolic murmurs. So systolic, it happens between S1 and S2. So why is that? It's because S1 is the closure of the aortic valves, and S2 is, the S1 is the closure of the AV valves, and S2 is the closure of the semilunar valves. Okay, so if you think about it, when the ventricle starts contracting, it will push against the AV valves, it will close it, and then it will push the blood out to the aortic and the pulmonary arteries. And then when it closes, when those valves closes, it's because the ventricle is relaxing again. So any murmur that you hear between the S1 and the S2 is a systolic murmur, okay? And some causes of these is, okay, so imagine that, okay, that the ventricle is contracting against a stenotic aortic valve, so it will cause a murmur, okay? And if, for example, the mitral valve is incompetent, so when the ventricle contracts, the blood is going back, it will cause a murmur, okay? And the same goes for the atrial septal defect, which is a hole between the atriums, or ventricular septal defect, which is a hole between the ventricles. Okay. So now for the diastolic murmur, it's a murmur that happens after S2. So basically you will hear S1, S2, and then a murmur. Okay, this happens when the ventricle is in diastole. So what happens in diastole? The blood is going from the atrium to the ventricle. Okay, and so basically, if there's a stenosis in the in the mitral valve, it will cause a murmur. Also, it happens if there's aortic regurgitation. Okay, so basically, the ventricle, it will contract, it will push the blood to the aorta, and then the blood will come back, it will close the semilunar valves. This is normal. But if the valve is incompetent, it will come back into the ventricles, and this is when it causes a murmur. Right. So now for the hypertrophies. So basically, there is concentric hypertrophy and there is eccentric hypertrophy. Concentric is when the ventricular wall is thickened. So here you can see in the picture, the ventricle is thicker. It can affect the ventricular chamber diameter, or it can't, or maybe it can be normal. Okay. So we said here that if there is a pressure overload, the ventricle is contracting against a high pressure for a long time. So basically, the muscle will get bulky. It's like in the gym. If you're using a very high weights, your muscle will become bulkier, right? So it's the same thing for the heart. So when this happens, the ventricle becomes not compliant. So this is when you hear the S4 sound, as we said. And the eccentric is, it happens when there's a volume overload. So volume overload, remember that it's S3 heart sound, okay? So this happens when there's a lot of blood coming back into the heart. So it will cause the ventricle to dilate more. Okay, there's an increase in the ventricular diameter. And this can come with ventricular thickening, or it can be not present. Okay. Okay, so here if there's any questions. Okay. So now for the heart for the valve abnormalities and its effect on the PV loop. Okay, so just a quick review of the normal PV loop. So basically here you have the ventricular filling. So mitral valve opens. The blood will pass from the atrium to the ventricle. So you will have the ventricle, it will start filling. You see that there's an increase in volume. Here you can see on the x-axis, there's the left ventricular volume, and on the y-axis, there's the left ventricular pressure. So the volume, it will increase, and then the mitral valve will close, right? And then the ventricle, it will start to contract. There is the isovolumetric contraction. There is no change in the volume. The pressure is just increasing. And then it's until the aortic valve opens, right? And then the volume, it will decrease because you're pushing the blood out of the ventricle to the aorta. So the volume, it will decrease until the aortic valve closes. And then there is the isovolumetric relaxation, okay? So when the mitral valve closes, this is the S1, and when the aortic valve closes, this is the S2. And then basically you have here the end systolic volume, because this is when all the volume of the blood, it comes out of the ventricle, not all of it, but when the contraction ends. So this is the end systolic volume, okay? This is the blood that's left in the heart after systole. And here you can see that there's the end diastolic volume. So it's the end volume from the filling of the ventricle, okay? And the difference between them is the stroke volume. So here you can see in this diagram, the pressure against the volume, okay? And how does the compliance affect them? So the normal, you will see that when the left volume increases, there will be an increase in pressure. It's not linear. So not linear, it means that it's not a straight line, because in higher volumes, the left ventricle will not stretch more, so the pressure will increase much more faster, okay? And then, so basically, if there is decreased compliance, so if you have concentric hypertrophy, there will be a decreased compliance, right? So here, when the volume increases, the pressure will increase much more fast than the normal one. And then if there's increased compliance, the pressure, it will increase slower than the normal, right? Okay. So now let's go into each valve disorder and how it affects the PVU, okay? So aortic stenosis, we said that it's a systolic murmur, right? Because when the ventricle contracts, it will push against the aortic valve and it will cause the systolic murmur. Right. So basically, it will cause a concentric hypertrophy. And this is when we hear the S4 sound. So here you can see that the murmur here is systolic. It's between S1 and S2. It causes a crescendo, decrescendo. Okay. So let's see how it affects the PVU. So basically here, you have the ventricular filling, and then the ventricle, it will, this is the isovolumetric, right? Contraction. So it will be much higher because you're pushing against a stiff aortic valve, so the blood is not coming out easily. So here, this is why it will be much higher. And then because the valve is stiff, so not a lot of blood it will go to the aorta. So here you will find that the end systolic volume is higher. So there is more blood left in the ventricle. Okay. So here you can see that there's increased systolic volume and there's a decreased stroke volume. Stroke volume is the difference between the end diastolic volume and the end systolic volume. So here you can see it's narrow. So there's a difference between, there's a decreased systolic volume. Okay, so for the mitral and tricuspid stenosis, so here you can see in the diagram that it's hard to push the blood from the atrium to the ventricle, okay? And this pushing of blood from the atrium to the ventricle, it happens during diastole, right? So it's a diastolic murmur. Here you can see that there's the S1, the S2, and then there's the murmur here. It's after S2. Okay, so the atrium, it will work hard to push against the mitral valve. So you will basically, because it's not able to push the blood to the ventricle, so there is more accumulation of blood in the atrium. It will cause the atrium to be dilated. Okay. So here on the PV loop, so you will see that there is ventricular filling, but since the atrium is not able to push that much blood into the ventricle, so you will see that the end diastolic volume is decreased. Okay, it's not able to fill to the normal. And then there is the isovolumetric contraction, and then the ventricle, it will contract normally because the contractility of the ventricle is normal, so it will push, and you will find that the end systolic volume is even decreased because basically the contractility is the same, and you have less blood, so it's pushing out more. Okay. So you will have a decreased EDV or end diastolic volume or preload, and you will have decreased afterload, but not that much. So you will see that the stroke volume, the difference between them both, is decreased. So here you can see the P wave. The P wave, it's in the action potential, right? So so it's you will find it on the ECG. So the P wave, you will find it on the ECG. So here, it's the contraction of the atrium. So there's the basically this P wave is divided into the right atrium and the depolarization of the left atrium. So if let's say that there is a left atrium hypertrophy. So the contraction of the left atrium, it will be higher than the right atrium. So you will see that there is kind of a hump in the P wave. But if there is a hypertrophy in the right atrium, so that means that this wave, it will be larger, so it will pass over this left atrium bump, okay? So it will just create a very large P wave. Okay, so now for the aortic and pulmonic regurgitation. So what happens here is that in diastole, when the ventricle starts relaxing again, the blood, it will come back from the aorta to the ventricle. Okay, so when does this happen? In diastole, so it causes a diastolic murmur. So you will see that here, that S1 and then S2, and then there's the murmur. Okay, so what happens is that there is an increased systolic blood pressure because there's an increased systolic blood pressure because basically we said that it causes a volume overload. The blood is coming back from the aorta and the blood is coming from the atrium. So there's an increased preload in the ventricle. So here you can see it in the PV loop that the ventricle is filling, and there is an increased diastolic volume because it's coming from two places, from the aorta and from the atrium. Okay, and then the ventricle, it will push, and it will basically okay. So basically, when the ventricle, it pushes the blood to the aorta, some of the blood will come back. So this is why there is a decreased diastolic blood pressure. So here the blood will come back to the ventricle. It will cause an increased end systolic volume. So and the increase in the systolic blood pressure and the decrease in the diastolic blood pressure, it will cause an increased pulse pressure. Okay, and because we said that it's a volume overload, it will cause an S3 heart sound. Okay, so now for the mitral and tricuspid regurgitation. So when does this happen? So if you think about it, that the mitral valve, it's incompetent. So when the ventricle contracts, it will pass the blood to the aorta, and some of the blood will come back to the atrium. Okay, so this happens when the ventricle contracts, so systole. So it's a systolic murmur, and you will see that it happens between S1 and S2. You will find that the murmur is the same. It's not crescendo, decrescendo like the aortic stenosis. It's hollow systolic murmur. So what happens here is that there is increased filling. There is increased so when the ventricle it fills, basically because the blood is going back to the atrium. So when the atrium contracts, it's pushing more blood into the ventricle. Okay, so it will cause an increased end diastolic volume. And then the ventricle, there is the isovolumetric, and then when it contracts, it basically it's sending blood to the atrium, to the aorta and the atrium. So there will be less blood left in the ventricle. So there is a decrease in the end systolic volume. Okay. But okay, so let's explain it here. So there is increased preload. So we explained that because there's more blood in the atrium. There is a decreased systolic blood pressure because basically because the ventricle is pumping out blood, but it's going to two different places. So it's not all going to the aorta, so there's a decrease in the systolic blood pressure. There is increased total stroke volume. So the ventricle is pushing more blood. The total stroke volume is so it's pushing more blood, but it's not all effective. The effective is the blood that's going to the aorta. So there's a decreased effective stroke volume, and there is a decreased end systolic volume because less blood is left in the ventricle. Okay. So any questions? Yeah. So now for the questions. So a 78-year-old male presents complaining of dyspnea on exertional angina for the past 3 months. On exam, you note a systolic murmur when your stethoscope is placed over the apical area. Apical, it's the same as the mitral area. Which of the following is the correct murmur? Okay, so because it's a systolic murmur, so it's either aortic stenosis, um, okay, so a systolic murmur, it's either aortic stenosis or mitral regurgitation, right? And then because they said it's apical area, so that means it's mitral. So B, yes, correct. Okay. So a 32-year-old athlete presents with a routine physical exam. During auscultation, a soft split of S2 is noted that widens during inspiration. He is asymptomatic and has no significant medical history. What is the most likely cause of the split S2 heard during auscultation? Okay, yes. So I see a C. Right. So basically, we said that there is a normal splitting of S2 that's caused by the inspiration. So we said that there's a decrease in the intrathoracic pressure. It will allow more blood to enter into the right atrium through the vena cava, and it will cause more blood to be in the right ventricle. So it will so the pulmonic valve, it will close later than the aortic valve because the ventricle, it needs more time to empty. So it's physiological splitting due to normal breathing variation. And we said that the pathological one is not does not widen during inspiration. Okay. So for three, which of the following causes a diastolic murmur and an S3 heart sound? Okay. So basically, diastolic murmur. So when the ventricle is in diastole, so what can happen is aortic regurgitation, aortic and pulmonic regurgitation, or there is um, okay pulmonic or mitral stenosis. Okay, mitral and tricuspid stenosis. So because we said that there is an S3 heart sound, so there is a volume overload, okay? So volume overload, it happens when there is pulmonic regurgitation, okay? Because okay, 1 second. Because the blood is coming back from the pulmonic artery and also from the atrium. So there's going to be a volume overload, and this is why we hear the S3 heart sound. It's not going to be mitral stenosis because in mitral stenosis, there's the atrium is pushing against a hard mitral valve, so that will cause an atrial basically hypertrophy or dilation because there is more blood there. Okay. So now for the last question. Which of the following PV loops shows aortic stenosis? Yes, A. So here, you can see that there is ventricular filling. The ventricle is pushing against a hard aortic valve, so it needs more pressure. And then because the valve is also stiff, so not all the blood, so it cannot push as much blood out. So you will see here that the end systolic volume is increased. So there is more blood left in the ventricle. Okay. So it's A. Okay, so that's it. Thank you. And if you have any questions, also please scan the barcode.